colleagues and friends, we continue our video series regarding and dedicated to case discussions and case reviews. And this time we will be glad to present to you our second case related to aesthetic rehabilitation. The second case that we promised to send participants of our online masterclass, online webinar, and we actually keep our promising. So we are recording this case, and we will continue to make this case reviews in regular basis. So follow us on our YouTube channel, switch on notifications, because every single week you'll be able to see new case discussion, and you'll be able to get some clinical tips and tricks, and useful information absolutely for free. Okay, so let's go. A new clinical case, the clinical case that we call hybrid restorations. Actually, you will see how can we combine within one clinical situation, how can we combine different types of materials like ceramic and composite together. So I would like to present you our patient, and I will start with main complaints. So my patient was not happy with her smile. She wanted to change color, she wanted to change shape, and also she wanted to change display of her teeth. She said me literally that her smile is pretty narrow. She doesn't like when she smiles, the teeth are really small. And if you will just take a precise look over her smile, you may see that smile is not relaxed. It is pretty tensed here because of the mimic muscles. I think that patient hides something. By the way, if somebody has any aesthetic imperfection, they try to mask them by a specific way of smiling. In this case, if you would just imagine a wide smile by this patient, you will definitely see pretty big buccal corridors. So that was a reason why patient said that my teeth are small and smile is so narrow, and I would like to improve everything with restorative and aesthetic treatment. So another thing is, we analyze every single picture, every single portrait that we have, because every single photograph, it gives us a lot of useful information. We discussed this topic during our online webinar dedicated to aesthetic rehabilitations and treatment plannings. So in this case, I'll go a little bit more detailed into information that we get out of this picture. So the second picture, as you remember from the protocol, is the one when you ask your patient to be really relaxed, and then you ask your patient to open mouth slightly, just like a semi-opening of the mouth. And you can see display of frontal teeth. And there is a study by Wig that shows us, let's say, normal display at different ages. When people are at the age of 30 years old, they may display upper teeth up to 3 millimeters, and lower teeth, lower incisors, are less than 1 millimeter. As elder we become, as more lower teeth will be displayed and less upper frontal teeth will be displayed. So how do we interpret this information? What kind of information we get out of this picture? First of all, if you have a young patient, for example, and you see that the display is not enough, the first thing that you may think about is to make these teeth longer. So necessity to make teeth longer can be based also on that picture. It is not absolute information, because sometimes, especially nowadays when you have a lot of exaggerations in cosmetology, when young people, young ladies, they start to do some fillings in their lips, and lips become really big, and you cannot see teeth because of the lips, but not because of the length of the teeth. So this is another story. Also, it's crucial to get and to evaluate pictures of 45 degrees or 90 degrees pictures, which means profile pictures, because these pictures, they tell us a lot of useful information. For example, this patient, you can see, has retroclined frontal teeth. Okay, so they are retroclined. If it is good or not, let's discuss why we point attention on that component of smile, the retroclination of teeth. From aesthetic point of view, from restorative point of view, let's say in terms of the treatments, okay, treatment-wise, if it is good or not. Restoratively, it's good because you have space to add. So actually you can be really non-invasive. You can put veneers or even some prepless veneers, or you can do the composite restorations without preparing teeth. So this is really good for that component. But if you will need to make teeth longer, as we already discussed, and patient wanted actually to make them longer, and also I saw that they should be slightly longer. In this case, retroclination is not a good option to make teeth longer, because if teeth are already retroclined and you make them longer, you interfere into the envelope of function. So you are literally, you make envelope of function restricted, and there is no room for lower jaw to move forward, and that's why these teeth may break, veneers may break, may abrade, and may get some muscle problems, because, for example, to move jaw more slightly forward, patient will have to open mouth more and then to move more, open more and move, and so it may cause some muscle problems or even sometimes joint problems, or sometimes maybe everything will be all right. Sometimes this happens also, but you have to understand that in this case, when you make this longer, you are in a group of risk. Okay, so let's go back to intraoral picture. We would like to analyze also intraoral picture because it is super important. Take a look here. Here is composite restoration, also composite filling here, lateral incisors, canines, some caries defects here. Okay, so all this has to be evaluated also before you will start doing something with patients. So basically, we were discussing with you consultation, we were discussing with you aesthetic treatment planning, and also during this step we can even analyze and plan preparations. So in this case, in terms of preparation, for example, if we will go for that case in terms of restorative dentistry, veneer case, to prep or not to prep, in this case we can be really non-aggressive. In terms of the volume of teeth, we can be non-invasive, but considering the fact that we have composite fillings and caries defects, we have to open interproximal spaces and to do type 2 and type 3 veneer preparations. Okay, so this is also important for us to understand this and to plan preparations in advance, to have a guideline for ourselves in order not to forget any single step that we have to apply during the process of treatment. Okay, so summary: color issue, cervical discoloration. It was about A3.5 color. Then class 3, class 4 decays, and necessity to make smile more wider and teeth slightly longer. Let us also analyze her intraoral occlusal pictures, because here you may have a lot of interesting thoughts regarding the treatment planning, and everything that we will discuss right now was offered and provided to our patient, because it is important to highlight some options of treatment for the patient. So in this case, you can see her arches are narrowed, and her lower teeth and upper molar teeth, they are almost intact. The ideal way in this case to provide aesthetic treatment and minimal invasive treatment is to do orthodontics. By orthodontic treatment, we may make pretty wide arches, and then you can place veneers and everything you want you can do, and everything will be perfect. We offered our orthodontic treatment. At that period of time, patient said if there is any other option that can solve aesthetic problem, and then I start to realize, if I will do restorative treatment, would I be invasive or I wouldn't be invasive? So in this case, considering the position of her teeth, we can be really non-invasive, but considering the necessity to make teeth longer, we will have to do something else. So basically, we have three options in order to make teeth longer and to be safe. First, we can increase VDO, to get some room. Another option, orthodontic treatment to make teeth protrusive. And another option is more aggressive preparation of lower third or incisal third of upper teeth, and artificially we can move them forward with the porcelain veneers, and also we have to make some adjustments of lower teeth just to make them slightly inclined, so that will be more smooth pathway and actually envelope of function. In this case we decided to go for first option, and the good thing is that knowing the length of central incisors, when we utilized templates, golden standard templates, we can actually know exactly how long teeth should be. So we can guide our dental technician when he will make wax up, and then to do occlusal rehab driven by aesthetic component. This is the way we follow these concepts. We make teeth. We define the central incisor length, and then it will be easier for us to perform occlusal curves. Okay, so we gave to our dental technician this information. So we collect all the data, including intraoral pictures, portrait pictures, patient complaints, necessity to make teeth longer. So we give to our dental technician some info, and we got back wax up in articulator with all teeth restored. We got also some silicone indexes to do functional and aesthetic mock-up. In that case, I used transparent silicone index as for aesthetic mock-up, because that time I didn't have bright colors of bis-acryl material for the mock-up. It was only A2 or A3, and we would like to see the BL shade, let's say. So I used a flowable composite, BL flowable composite, and then we made this mock-up. And when we got this mock-up, personally I was not super satisfied. My patient was not satisfied as well, but patient actually during consultation stage insisted on that rectangular shape of teeth, because she didn't like her more sophisticated and rounded teeth, and she asked us if we can make teeth more stronger, let's say more bigger, more angled. And then we got this result. The central incisors pretty long, two sharp corners, canines are also long. So this is good, because you can then prove to your patient that your vision of shapes of teeth, of patient smile is more better, I think, because it is based on some experience and some aesthetic parameters. So basically what we did here, we just made adjustments of the mock-up. I took soft flex disc, make teeth slightly shorter, make them more rounded, whatever. And if you do any single adjustment of the mock-up, you will have to take an impression, because this impression will guide your dental technician regarding the shape that your dental technician will have to give you after actually for final veneers, let's say. If you work in analog way, because this is the case when we were doing this dentistry in 2012, so it's pretty long time ago, that we didn't have any intraoral scanner and any digital protocols were not used. So once we got acceptance, once we were satisfied by shape of teeth, we started preparations. So our preparations were guided through the mock-up. We discussed with dental technician color. We discussed with dental technician space that he has to have. In other words, we discussed with dental technician how thick veneers should be in order to change color from A3.5 into BL shade. And he gave me some number, let's say 0.5 or 0.7. Then I took my depth cutter and I started to prep teeth through the mock-up with that depth. And you will see later on, once I finished my step 1 preparation through the mock-up and then I removed this mock-up, you can see that teeth were not touched. So prepless preparations. We made finish lines. We prefer to do finish lines because it is easier than to fabricate veneers, then it is easier to isolate case, to bond veneers, and to polish transition between veneer and tooth. That's why we do this finish line. Okay, so let us take a look on the final preparation. As I mentioned, due to composite restorations and caries defects, we made type 2 and type 3 preparation. Here is type 3. Between central incisors we open interproximal area completely. Type 2 preparation here and here. And canines were prepped for type 2 preparations as well because of small caries defects class 3. If you want to learn more about types of preparations and types of veneers, I would refer you to attend our online masterclass that is called Clinical Aspects of Tooth Preparation. You may find also a link below this video. In description of this video you may find link to our webinar about aesthetic treatment planning, and also you may find some links that will follow you to attend our online masterclasses about veneer preparations in clinical cases when you have class 3 or class 4 or class 5 caries defects. We have a lot of information there. And if you would like to get to enhance your practical skills, I'll be more than happy to host you here in my training center during our hands-on intensive courses about tooth preparations, which is module 1, and the course about all about veneers is module 3, so you are more than welcome, my friends. Okay, let's go, let's continue. So this is before and after preparation, actually, before and after preparation, and here we have final result straight the same year. As for posterior teeth, because I mentioned that we had to increase video in this particular case, and analyzing cast models and wax up, we got a conclusion that we should just add a little bit of material on occlusal surface. And since teeth are intact, I was really, was not comfortable to prep these teeth for overlays or occlusal veneers. So I decided to go for transitional bonding or for copy-paste, actually for copy-paste technique. I took impressions with a transparent material from the wax up, and I started to restore teeth through this transparent material, utilizing the wax up as the guide. In this case, I used tip to protect adjacent teeth with a metric system. On previous case, the case number 1 that I shared with you, we showed you Teflon between teeth. And actually, this is one of the first cases when we were using this copy-paste technique, and I didn't have enough experience in that component. So we put some matrices. We cut matrices in order not to have interference between matrix and silicon index. And this is a rigid thermoplastic material. It is not transparent silicon index. And in this case, I didn't reline actually this rigid tray with a transparent silicon index, and you can see that after copy paste the anatomy was not perfect. It's like a main anatomy was done, because the thermoplastic material that is done in vacuum former, it's not super precise to give you reflection. If I would know the trick, because that time I didn't know that trick, that I can reline it with a transparent silicone, because silicone is soft and it can reflect a lot of details. In this case, I did 2 steps actually. I made some small room within this composite, and then I did freehand layering technique. So nowadays, if you do reline with a transparent silicone, you do copy paste and everything will be done from A to Z immediately. You'll save a lot of time, and there are some tips and tricks. How can you avoid that overhangs in between teeth in order to save your time for finishing and polishing. This picture was taken actually before I did my final finishing and polishing. That's why we have here overheads. But anyways, we were able to do that type of posterior restorations prepless in areas where there was no caries defects. There were no caries defects, so just sandblasting. We did sandblasting. Then we did what? We do etching, rinsing, bonding, putting composite, press, light cure, then remove excess, and that's it. And you can see combination with the ceramic veneers. Ceramic veneers we used for upper arch from 5 to 5. These teeth were restored with porcelain veneers. The rest of them were restored with a copy-paste technique with utilizing composite materials. And lower teeth were actually restored with add some little bit increments of composite, and they were where we made bleaching. We made bleaching here. One more interesting thing about this case: this central incisor, this one, is made of composite. So this line here is composite restoration, and this patient that I'm sharing with you, her case, is my old friend, We used to be actually our classmates. She's now a partner in the educational field, and I made an endodontic treatment in 2007. Imagine that. And then I did some direct restorations. Then I remade composite restorations. We failed color. So this is a learning curve, you see. Everybody learns from mistakes, and I'm not an exception. So we just made some adjustments and redesign or whatever, and finally we end up with porcelain veneers, and one of these porcelain veneers was bonded to a really big portion of composite. So many people still, they're really afraid to do that kind of combination, but we have evidence nowadays, we have clinical experience and clinical follow-ups, but also we have evidence where you can find a lot of articles. One of these articles I'm sharing with you, the article when you can say that it's proved that combination between ceramic and composite works. It's 11-year prospective clinical trial, by the way, in this article. If you will follow proper bonding procedure. So you do sandblasting, you put silane, you bond, and then you bond your veneer. So this is in a really brief way to provide bonding protocol to bond your ceramic to composite. I have my own result here, which is more than 7 years, which is pretty good, nice result. Everything is okay, everything is super perfect. I'm really happy. My patient also is super happy, and we got this result. You can see from that video, the soft tissues pretty healthy. Everything is super perfect. No plaque, no inflammation. Everything is really fitted well. Biological integration is perfect, and everything that we did in this case was really minimally invasive. This is what I would like to highlight. We made proper consultation, we gave options to our patient, then we evaluated aesthetic components, we designed smile, we referred this information to dental technician, then dental technician gave us wax up, we performed preparation for upper arch of utilizing porcelain veneer as the final restorative materials, and we used copy-paste technique as the hybrid restoration for posterior teeth. So that is pretty complex case with the different techniques and their combination that were based by proper aesthetic and functional treatment planning. Okay, this was the short conclusion. So we're actually about to finish this case number 2. I would like to ask you again to write down in comments what kind of clinical cases you would like us to share, what kind of information you would like us to share with you, and we will record in next episodes, we will record something interesting according to your requests. Don't forget again to subscribe our YouTube channel and to switch on notifications. For those who want to attend our webinars, you can find links below this video. For the rest, I wish you all the best, and see you in next video episodes here on our online educational platform, BG Academy. Bye-bye.